Hi, I'm going to give this a shot. I'm having a real rough time with some of this technology. Anyway, the title of my project was The Effect of Implementing Symptom Feedback into Psychiatric Care at a Nonprofit Clinic. For the last decade, healthcare has been moving toward value-based care, where we are being looked at and paid for how we do, not what we do. This holds true for hospitals and clinics, but also for charity clinics, because grant funders want to see a return on investment for donated dollars. In these situations, measurement-based care and tools can really help. Now, the problem that I had, the local problem, was that a local charity clinic really felt they were doing a good job, but needed outcome data to add to grant requests to encourage donations and grants. They had nothing in place to do this, and I thought that measurement-based care could work. But the global problem, when I looked at it, is that most providers, while they recognize that measurement-based care is evidence-based, they don't use it in daily practice. Well, why not? So I thought, what am I up against if I try to institute this? So I looked to the literature. And what I found was that there were three major objections to their use in psychiatry. One, with time-limited office visits, there just wasn't enough time to fill out these forms and actually review them with patients. The second thing was that many felt that their clinical judgment superseded a tool and that they really just didn't need it. The third was that people assumed the patients wouldn't like doing it, filling it out, that they would feel it's too impersonal, too cold, and that they would be resistant to being involved in that. But for each of those objections, there are multiple studies that refute these claims and attitudes, so that in fact it's a time saver. The clinical judgment scores are really equal to all tool measurements in many, many studies, and the patients actually like it. They feel more engaged and they feel like people are really interested in what's happening with them. So it's mostly about resistance to change and providers saying, well, this is the way we've always done it, we're fine. The thing was that I did find one study in all of the various studies who actually addressed the barriers to change and offered a key to an implementation strategy to changing providers' attitudes and behavior regarding measurement-based care, or MBC. They made sure the providers saw the scores. And with time, the providers realized how valuable it was. And that was the idea for this implementation study. So my PICO question was, in psychiatric providers at a charity-based clinic, what is the effect of proactive reporting of scores on the patient-reported PHQ-9 tool for depression and GAD-7 tool for anxiety, as compared to care as usual, on treatment outcomes and provider perceptions of measurement-based care? So I had three objectives. The first was to institute the use of the tools on every patient at every visit. I was hoping for a 90% patient response rate. The second objective was to measure the patient scores on the tools before and after an intervention, where I would proactively report their trended scores to the providers for a block of time. And then the third thing was to gather information on their attitudes afterwards, to see what they thought not only of MBC, but of the initiative overall. So the theoretical framework that I used was Ronald Lippett's theory of change in nursing. This is a 7-step method that follows the nursing assessment process, and it's predicated on the use of an external change agent who enters, assesses, implements the change, sets it up for sustainability, and then exits the relationship. In this model, change agents are very active parts of the process, managing staff and supporting the initiative, and being very highly involved to make it happen. The study design and method, this was a quality improvement implementation initiative with an exploratory mixed methods design. It entailed a pre-test, post-test quantitative measurement to look for changes in scores over time, both before and after the reporting intervention. This was followed by a 6-question semi-structured interview exploring attitudes toward MBC in general and the effect of the intervention in specific. It was approved by the JMU IRB. So what was the intervention? Well, essentially what I did was, in order to effect change, I took a look at the existing workflow and made a minor tweak to how things were done. On check-in, clients were given a clipboard that had the tools on them to complete. They were educated on what they were about and also educated to plan to come and be self-reflective on how they were doing, so that they would be able to fill out these tools to actively represent how they were doing. They handed them back to the office assistant prior to their visit. Once a week, I would collect the scores, and then I would load the results into the screening section of the chart in the electronic medical record. The scores were available for all the providers to see if they wanted, and they had been informed that we were going to start doing these measurements and that the scores would be in the chart for them to see. So what I did was I started in mid-November with obtaining the scores on patients. I had baseline scores by January. By mid-March, I got a second measurement of how the patients were doing on these two tools. After I got that measurement, I then would go in, take a look at who was coming in that week, which providers, which patients, and I would send by email the trended scores of that provider's patients for the week, so that every Sunday they knew that they would get all of those scores. And they responded to me, so I knew that they were actually getting them. I continued to do that for an additional 3 months, and then got a final score on everyone. And after that, I began the qualitative interviews. My timeline, actually the entire project went for about 1.5 years, because it entailed getting buy-in from the board and from the executive director, having to learn how to use the EMR, teaching staff how to use it, rolling it out, and then doing all of these things in the process. So the setting was a psychiatric clinic that's run under a nonprofit community agency. It is staffed by volunteer psychiatric providers who come and give their time so that they can provide psychotherapy, medication evaluation and management, and they receive the medication itself. Clients are uninsured, under 200% of the federal poverty level, and ineligible for services from the state agency. They received all of their services on site. Most of the providers offered their services face-to-face, although one did it by teleconferencing. The sample was actually the providers. It was a non-randomized convenience sample of all the providers at the clinic. It included 6 third-year psychiatric residents who were there for a psychotherapy rotation for their residency, 1 fourth-year resident who was volunteering there and provided therapy and med management. I had 1 LCSW, 1 psychologist. They both provided psychotherapy. I had 1 Psych NP, 1 Psych PA, and 4 board-certified psychiatrists who all provided medication management. All the residents had practiced for less than 5 years, and the rest had been in practice for over 5 years. The tools that I use are well-validated and standardized tools that are actually recommended by the Center for Medicare and Medicaid Services to use for much of their meaningful use information. It's the Patient Health Questionnaire 9, or PHQ-9. This is a 9-question validated self-report tool for the presence of symptoms of depression. It's rated on a scale from 0 at none at all to 3 occurring most days. The Generalized Anxiety Disorder 7 tool is a 7-question validated self-report tool for the presence of symptoms of anxiety, rated also on the scale from 0 to 3. These scales are now public domain and have been used since the late 1990s, so they are well validated, reliable, and valid. The analysis. Okay, I ran dependent t-tests to look for differences in the means at each of the 3 measurement points: the baseline score, the score at 3 months, which is the last score before I started doing the reporting intervention, and then another 3 months later at the end. So it encompassed 7 months of data gathering in total. I used a linear mixed model repeated measures ANOVA with time as the within subjects factor and patient gender, provider discipline, and treatment modality as between subjects factors to take a look and see whether any of those had any impact on the results that I got over time. The qualitative interview, the interviews were recorded and transcribed, reviewed, and coded by 3 independent coders until saturation to identify sub-themes and themes in the narratives. I did also run a univariate repeated measures ANOVA at one point to further explore differences within gender that I found once I had actually gotten the data. So my findings. Over the course of the full 7 months of data, there was a significant reduction in symptom severity scores for both anxiety and depression, showing that the providers were very effective treating their patients. And this was great information for the clinic to have. This, it was statistically significant at p of less than 0.001. When it came to looking at the depression, the results with depression, it didn't seem to have much in the way of an impact, the intervention itself, but I explored this a little bit later and found some interesting results. There was a significant, though, reduction in anxiety during the intervention period. The scores dropped significantly during this period. With the ANOVA, I ran pairwise comparisons. It again showed a main effect for time that was, echoing what I found in the t-tests. There were no main effects for provider discipline or treatment modality, but gender was a different story. What happened with gender was that I got some results that had me stumped, as well as the statistician that was helping us out. There was an odd difference in the means between and within genders. It wasn't statistically significant, but there was a definite trend, so I performed a univariate ANOVA to explore it further. Males had a rapid reduction in symptoms, but rebounded later in treatment to near their baseline. They also started out at a much lower acuity level than females did. Females started with a much higher acuity score, but made a slower, steadier decline with a significant reduction overall, obviously driving that result for depression. And you can see on the slide that there is a steeper reduction during the intervention time period. I would suspect that that may become more pronounced with a larger N. And this bears some further exploration, taking a look at treatment response by gender, because it really was quite striking. When it came to the qualitative analysis, there were 338 references that were condensed to 64 codes, which were categorized into 14 sub-themes and 4 global themes. To address triangulation, 3 separate coders were used on de-identified transcripts. Reflexivity was addressed as the PI had no preconceptions on what the findings might be, so I really maintained an objective curiosity as to those findings. The findings were pretty consistent with the literature, but there were some interesting differences in how providers use the tools. Also of note is that 0 providers looked at any of those scores prior to getting the reports on those, which makes you really question all of the things that we document in charts that no one actually takes a look at. So once I started sending the tools, it was a different situation, and several commented later at being quite surprised at the patient responses not being congruent with what they felt was, they felt that the patient was doing. And many of them, in fact, most of them, used these responses to guide treatment. The categories fell into these 4 themes that simply addressed barriers to MBC, the value of MBC, why MBC should be continued, the need for it, and then the operational processes. And there was wonderful, rich data that I got out of all of this. I also ran a table that looked at the frequencies and the means of the various codes so that you could see exactly how many times certain codes were used and what was the highest frequency of comments that were made. So when it came to the project evaluation and outcomes, there were driving forces and restraining forces. Driving forces were the motivation of the executive director and the board to produce outcomes. The restraining force, quite frankly, was the difficulty integrating the EMR. I ran into a lot of difficulty with that. People had trouble remembering their passwords, couldn't remember how to use it. I had to keep reteaching people over and over again. But by January of 2019, patient reporting was at 100%. So I met my first objective. Second objective, showed a statistically significant reduction in patient symptoms with effectiveness with the intervention, especially with anxiety, and females approaching significance for depression. So that objective was met. And then getting the provider comments that drove the adjustment of the office process for the sustainability and standardization of the process. So I did meet all three objectives. The strengths and limitations, the strength was the small size of the N and the clinic. I was better able to control the project and intervene with adjustments in a timely manner in sort of a cyclic fashion, in the PDSA cyclic fashion, so that I could keep the project on task. The limitations were the small size, the small N limiting the generalizability and transferability of the information. Had I had a larger N, some of those trending results would have been more definitive. There was also an issue with the time lag between the scores and the reports, because for some of these patients that may only come once every 2 months for medication management, I was reporting the prior visit scores, which may be 2 months old when I sent them and less actionable. So the providers really wanted to see those results in real time. The other thing was the refinement of the qualitative questions. Had I had the time, since I had to submit the questions to the IRB to review when I put the initial application in, I would have really liked to have resubmitted with some additional questions to explore some of those quantitative results, because they were really interesting, and it would have been interesting to hear what the providers thought of what they found. In terms of the practice implications, I think that the implementing any kind of a change, whether it's MBC or anything else, can be successful with small changes in workflow and a team approach. Sort of embedding some changes into the existing workflows made it a little bit easier to incorporate in and become part of the natural daily aspects of how things went. The results that I got, and just some really, as I say, rich data, just collecting the tools and the information on the tools is not enough. The whole point of these tools is to actually be able to use them as they were intended, so that it makes a difference in terms of treatment. So it becomes really important not just to collect data, but to use it. And so the end result for the sustainability, as I was exiting the clinic, according to my theoretical framework, was that 100% of the providers wanted to continue the use of this, but they really wanted to see it. They wanted to choose the tools of their choice that would be appropriate to the patient that they saw. What we did was to set it up that the check-in, the office staff would hand out the tools. The patients would come ready to reflect and respond on the tools. The patients would bring those tools into the session with them so that the provider could review it, would sign off on it, and then the patient at checkout would hand it back into the office assistant, who would then put it into the medical record. So it was a team approach where everybody was involved in making this work: patient, office staff, and provider. And ultimately, the clinic benefits from the quantification of outcomes, providers see the results of their work, and patients are actively engaged in their health care. Thank you.